This video is going to go over Chapter 25, the urinary system, Objective 4, the regulation of urine. Now, you can probably already figure out when we say regulation, oh my goodness, that's going to involve some hormones. So let's go ahead and jump right in. With the regulation of the glomerular filtration rate, autoregulation occurs. Now, your arterial blood pressure can go anywhere from 90 millimeters of mercury to 180. And what's interesting is while your blood pressure is changing, the glomerular filtration rate will still be maintained. So what is passing through the kidney is pretty much going to stay constant. Now, if the blood pressure, arterial blood pressure, drops below 90 millimeters of mercury, this could be due to hemorrhaging, meaning loss of blood, or dehydration. You're going to have the sympathetic nervous system kick in that will cause a dramatic decrease in renal blood flow and decrease in the glomerular filtration rate in order to maintain homeostatic blood pressure. So what that means is if you've got blood loss, we're really not worried about making urine at that point. We're trying to maintain blood pressure, especially for the brain. So blood flow will be cut off essentially to the kidneys to maintain blood flow to the most important area, the brain. Because if the brain isn't getting its blood flow, it doesn't really matter what anything else is doing anyway. So in case of severe loss like that, and you've got a severe blood pressure drop, the sympathetic nervous system will kick in and override glomerular filtration rate, maintaining its own autoregulation. So it will kind of come in and say, nope, you were doing fine, but we've got a major body-wide problem here, so we're going to come in and decrease blood flow to your area. Now, autoregulation is going to occur by if the afferent arteriole increases blood pressure, the smooth muscle of the afferent arteriole will constrict. So basically, that afferent arteriole that is bringing blood into the glomerulus has the ability to change diameter. So it's remember those blood vessels are wrapped in smooth muscle. So that smooth muscle, if it constricts, it's going to decrease the amount of blood flow into that area. And if you don't have enough blood flow into that area, the smooth muscle will relax, allowing that afferent arteriole to open up and provide more blood. So that's part of the autoregulation. It's kind of detecting itself and controlling its own amount of blood flow based on the diameter of that afferent arteriole. If increased flow rate is detected after filtration has occurred, so this is on the other end of the glomerulus, a signal will be sent out to constrict that afferent arteriole, resulting in a decrease in glomerular filtration rate due to decreased glomerular capillary pressure. So it's determining whether to increase or decrease that afferent arterial diameter based on what's coming out at the filtration level. So it's kind of interesting. Now, your sympathetic stimulation. So again, anytime you're dealing with regulation, you got your two body systems. You've got your hormones and you've got your nervous system. So this is the nervous system component. Sympathetic, remember, this is your fight or flight scenario here. So this is when a person is engaged in physical activity. So autoregulation maintains renal blood flow, which we just talked about, and filtration formation unless the sympathetic stimulation overrides it. Sympathetic stimulation causes small arteries and afferent arterioles of the kidneys to constrict, decreasing renal blood flow and filtrate formation. And again, this can be due to severe hemorrhage, intense exercise, shock. It can decrease the filtration formation to a few milliliters per minute. Remember, normal was about 125 milliliters per minute. Regulation of urine concentration and volume. So you've got regulation of urine volume and concentration by three mechanisms, hormonal mechanisms. You already probably know those. You just don't know you know them yet, maybe. Autoregulation and the sympathetic nervous system. So let's take a look at the hormone component of this. There are two hormone mechanisms that regulate urine concentration and volume. You should already know these, so this should be review. The renin-angiotensin-aldosterone mechanism. The stimulus for this being engaged is blood pressure. This is going to be low blood pressure, which will result in an increase in blood pressure. So the renin pathway results in an increase in blood pressure. So stimulus, we could put a little thing right here that means low blood pressure. So the stimulus is low blood pressure right here. The other one is your antidiuretic hormone mechanism. Now, this has to do with blood osmolality, the solute concentration of the blood. So a person who is dehydrated, let's say, and they have a high blood osmolality. Again, think dehydration. That's going to cause the antidiuretic hormone to be released, which is going to hit the collecting duct of the kidney, which we just talked about, and allow water to leave the collecting duct and enter back into the bloodstream. Okay, so you're conserving water. These two, while they are regulated separately, notice their stimulus are two separate things here. They act together to regulate homeostasis. So let's briefly talk about the renin-angiotensin-aldosterone mechanism. So renin, you need to know where exactly it's secreted. It is secreted by the juxtaglomerular cells that are located in the afferent arteriole of the juxtaglomerular apparatus. So let's look at that juxtaglomerular apparatus real quick. So right here it is. So let's take a look at that. You've got your afferent arteriole right here. And remember that afferent arteriole is bringing blood in towards the glomerulus. You've got your efferent arteriole in which blood is leaving. Okay, so it's gone into the capillary, the glomerulus here, and that efferent arteriole is taking it away. Now, look at what is sitting right here, and I told you all this in the previous video. That distal convoluted tubule, while we noticed it in the picture we saw in the previous objective, you know, it was all stretched out and we could see the entire nephron. But what's really happening is the distal convoluted tubule is right up here next to the afferent arteriole. And within that distal convoluted tubule, you have these special cells called macula densa cells, and they're located right here. And then in the afferent arteriole, you have these juxtaglomerular cells located right here. So those juxtaglomerular cells are what produces renin. So renin is secreted from those cells, which are wrapped around that afferent arteriole. When the pressure in the afferent arteriole drops, renin is secreted by those cells. So those juxtaglomerular cells are kind of monitoring the stretch of that afferent arteriole. So when the afferent arteriole has a small diameter, it knows blood pressure is low. So those juxtaglomerular cells will secrete renin. And then in addition, you've also got these macula densa cells over here that detect a drop in sodium ion concentration. So these macula densa cells, they're monitoring salinity. They're measuring the sodium content of the blood. So as basically at this point, you know, we're kind of making urine, so we're really on the other end. But depending on the solute concentration of salt as the filtrate is leaving the tubule, basically, if you detect a drop in sodium ion concentrations in this area right here, it will trigger those macula densa cells to tell, notice they're right next door, tell the juxtaglomerular cells to secrete renin. So you've got two signals that allow renin to be secreted. Either the macula densa cells are telling him to do it, or the diameter of the afferent arteriole is telling him to do it. Now, if you remember, when we talked about salt, you may be thinking, what's salt got to do with it? Water follows salt. So if you don't have a lot of salt, sodium, in this efferent arteriole, you also don't have a lot of water in the efferent arteriole, which means blood pressure is going to be low because the salt left the body. It didn't stay in the blood. This is a very good video to watch done by Armando Hasudigan. It's about 7 minutes long. You do have a handout in your packet that just helps you follow what we just talked about. See it a little bit differently, hear it a little bit differently. But it is a good video to kind of help understand visually what is going on in that juxtaglomerular apparatus. So, summary of renin release. When renin is secreted, it enters the blood and converts. I know y'all, it's been a minute since we've done this. Converts angiotensinogen, which is a protein produced by the liver, to angiotensin 1. So remember, renin and angiotensinogen is floating around the blood. And then when renin shows up, that's when you get angiotensin 1. That should be a G right there, not a T. That should be angiotensin 1. And remember, angiotensin 1 isn't really that big of a deal. It doesn't do a whole lot. But when it meets up with, that should be a G again, I can't spell, angiotensin converting enzyme found in the capillary beds of lungs, the angiotensin 1 gets converted to angiotensin 2. Now, angiotensin 2 is the big player in this mechanism. This is the one that does all of the down the line things. So when people have high blood pressure, they take ACE inhibitors because what it does is it prevents this angiotensin converting enzyme from being formed. Therefore, angiotensin 1 never gets converted to angiotensin 2. Again, angiotensin 1 isn't going to do that much. Angiotensin 2 is doing everything. Angiotensin 2, as you can see right here, is a potent vasoconstricting hormone that increases peripheral resistance, ultimately causing blood pressure to increase. It breaks down quickly, so its effect is pretty short. Angiotensin 2 increases the rate of aldosterone secretion, causing thirst, salt appetite, and antidiuretic hormone secretion. So again, potent vasoconstricting hormone. So aldosterone, if you remember, is produced in two ways. Aldosterone is produced when the adrenal cortex of the adrenal glands when blood pressure is low. So this is part of that renin-angiotensin aldosterone pathway. So when you have low blood pressure, aldosterone is going to show up. Now, aldosterone is going to increase the rate that sodium is resorbed by the kidneys, thereby increasing sodium levels in the blood. Remember what resorption means. This can lead to an increased water reabsorption by the kidneys, thereby increasing blood volume, which ultimately increases blood pressure. So again, you're doing two different things here, but ultimately the end result is blood pressure increase. Now, the second thing aldosterone, the other way it can be produced is increased levels of potassium act directly on the adrenal cortex to stimulate aldosterone secretion. Decreased levels of blood potassium will decrease aldosterone secretion. So it can either be secreted as part of that renin-angiotensin aldosterone pathway due to a low blood pressure, or it can act independently on its own and based on the potassium levels of the blood. It can go ahead and act, because if you remember, potassium and sodium are going to move in opposite directions because of that sodium-potassium pump. So if you have increased levels of potassium, that means you have low blood sodium. Okay? So here is that renin-angiotensin aldosterone pathway. Pardon me. So you've got a drop in blood pressure. Renin is going to be secreted by those juxtaglomerular cells of the kidney. It's going to cause the angiotensinogen in the blood to be converted to angiotensin 1. The ACE, angiotensin converting enzyme from the lung, will cause angiotensin 1 to be converted to angiotensin 2. Angiotensin 2 will act on the adrenal cortex, causing aldosterone secretion, and it will also cause a rise in blood pressure because that aldosterone is going to cause sodium, to be retained while getting rid of the potassium, which will cause a blood pressure increase because, again, water follows the salt. Same picture, well, same process, different picture. You have this handout as well. So you've got your renin right here that you can see being secreted from those juxtaglomerular cells. You can see those macula densa cells right there, which can be communicating with those juxtaglomerular cells in the event of a sodium issue. You can see here that that renin is going to enter into the bloodstream. It is going to get converted to angiotensin 1 when angiotensinogen gets released by the liver. that ACE enzyme is going to cause angiotensin 1 to be converted to angiotensin 2, which will stimulate widespread vasoconstriction. It will also cause the adrenal cortex to secrete aldosterone, which will cause sodium to be resorbed and water to be resorbed as well. Same information. I'll let you take a look at this. You've got this handout as well. Same information. Now, you've also got your antidiuretic hormone mechanism. Goodness. Yeah, I'll drink water. So, antidiuretic hormone is going to act on the distal convoluted tubule and the collecting ducts. They're relatively impermeable to water unless antidiuretic hormone shows up. Keep in mind that's also known as vasopressin. Antidiuretic hormone is going to be secreted from the posterior pituitary gland and target the collecting ducts. If you don't have enough antidiuretic hormone that can be released from the posterior pituitary, so if you've got a problem in this area here and antidiuretic hormone does not get secreted like it's supposed to, that can result in a situation known as diabetes insipidus. Diabetes means a large volume of urine, just like diabetes mellitus does, but the insipidus means your urine is clear, tasteless, and dilute. A person who has diabetes insipidus is creating about 10 to 20 liters of urine per day, as opposed to the 2 liters that is normal. Now, this can result in dehydration and ion imbalance, so this is definitely a problem. Now, with diabetes mellitus, this is still secreting large volumes of urine, but that urine is going to contain a lot of glucose because this is your sugar diabetes is what they sometimes call it. This has to do with sugar issues. So antidiuretic hormone, if the osmolality of blood increases, that means you got a lot of solute in the blood, possibly dehydration going on, then that's going to trigger antidiuretic hormone to be secreted. So that is the stimulus for secreting antidiuretic hormone is high osmolality, high solute concentration. If blood osmolality is low, then antidiuretic hormone will not be secreted. You've got baroreceptors that monitor blood pressure in the atria of the heart, large veins, carotid sinuses, and the aortic arch that also influence that antidiuretic hormone secretion. Antidiuretic hormone secretion causes an increase in water absorption through the kidneys, which means the water is going to go from the kidney into the bloodstream, so you're going to make less urine. You also have atrial natriuretic hormone. Now, keep in mind, this one is the one that does the opposite. Antidiuretic hormone is going to result in an increase in blood pressure because you're putting water back into the blood. Increase water, increase volume, increase blood pressure. Atrial natriuretic hormone is going to result in a decrease in blood pressure. It is secreted from the atrium of the heart, and when blood volume in the right atrium is increased, that right atrium is going to stretch more, resulting in atrial natriuretic hormone being secreted. This right here is showing you normal blood pressure and volume, and you can see right here when you have an increase in blood pressure and volume, atrial natriuretic peptide will be secreted, which will result in sodium loss in urine, increased water loss in urine, reduced thirst, blockage of ADH, increase peripheral vasodilation, so increase in dilation in those peripheral blood vessels. And then that will ultimately reduce blood volume, reduce blood pressure, and get you back to normal. So atrial natriuretic hormone affects everything in that same line that we talked about that causes an increase in blood pressure, but it just does, it's just one hormone that does the reverse of everything that we previously have talked about. And then that ends objective 4.